This is part 5 of a 6-part series, A Primer for Hearing Loss for Medical Students by Dr. Gregory Staffel and published by the American Academy of Otolaryngology. Sensorineural hearing loss is the most common form of hearing loss. It is generally not treatable with surgery, although cochlear implants and other implantable audiologic devices may be helpful in cases of profound sensorineural or mixed hearing loss. There are many causes of this type of hearing loss, but age-related changes to the cochlea causing presbycusis are by far the most frequent cause. As we age, the outer hair cells within the cochlea gradually deteriorate, causing a symmetrical sensorineural hearing loss that begins in the high frequencies. Patients with presbycusis may also complain of tinnitus and have difficulty with speech discrimination. Another common type of hearing loss is secondary to acoustic trauma or noise exposure. Noise exposure is common in certain industries and is closely regulated by a federal government agency, the Occupational Health and Safety Administration. Recreational target shooting, hunting with firearms, use of personal stereos or iPods or other MP3 devices with headphones, loud music exposure, power tools, etc., can cause a specific type of hearing loss with a characteristic audiometric pattern. Patients suffering from noise-induced hearing loss have a symmetric noise notch in bone conduction thresholds at approximately 4,000 Hz. Prevention is vital, and counseling should be part of routine health maintenance. Treatment consists of hearing education, noise avoidance when possible, and appropriate hearing protection with earplugs or earmuffs when loud noise is present. Patients should also have regularly scheduled audiometric follow-up. Sudden sensorineural hearing loss is an acute loss of hearing that represents an ENT emergency and deserves special management. Patients with asymmetric sensorineural hearing loss require a more thorough evaluation to rule out a benign tumor of the 8th cranial nerve, known as an acoustic neuroma. Although most patients with an asymmetric hearing loss do not have an acoustic neuroma, hearing loss is by far the most common presenting complaint in patients with such tumors. In addition, these patients will frequently have poor speech discrimination scores and tinnitus in the affected ear. They may also occasionally have disequilibrium complaints, although true vertigo is rare. Specialized audiometric testing can be done to assist in the diagnosis of acoustic neuromas, but MRI with gadolinium is the diagnostic test of choice. Physical exam and testing may elucidate an easily treatable cause of hearing loss. However, more serious causes can be present that require careful assessment and complex management. To ensure that diagnosis of serious conditions such as cholesteatoma or acoustic neuroma are made, patients with hearing loss should be referred to an otolaryngologist for evaluation and management of their care. For this reason, many states require an evaluation by a physician before a hearing aid can be fitted. Be sure to subscribe to our channel and learn more about hearing loss and how primary care practices can better serve patients in this capacity.